Okay, so we want to welcome everyone to the next installment of UOA On Demand. We're going to talk tonight about meniscus tears, and we have three people who are certainly very accustomed to seeing this in the office, and we're excited to have a discussion to hopefully give you some more information. My name is Dr. Patrick Buckley. I'm joined by Dr. Kenneth Swan as well as Dr. Charlie Gatt, and we're all part of the sports medicine department here at UOA. Guys, how are you? Welcome.
Hello. Okay.
So, I thought I'd start with just a little bit of a background for those watching about, what a meniscus tear is. What a meniscus is, which is really kind of a cushion pad or a C-shaped structure that is in your knee. You actually have two meniscus in your knee. One's on the inside, your medial meniscus, and then you have one on the outside of your knee called your lateral meniscus. And, these are things that when they're functioning and when they're not torn, do a couple things, but for the most part, really provide like a cushion pad to distribute forces as you go throughout your day and protect the cartilage of your knee. They also have some role in stability, and when they're working great, that's kind of the job. But what we're going to talk about tonight is what happens when you have a torn meniscus. Dr. Swan, I'll kind of maybe start with you, and if you can, just go through what you would typically listen for, both for the history and how meniscus tears happen, because I think that's good for patients to hear when they think they may have one.
Sure. I think of meniscus tears basically in two categories, because we tend to see them a lot in the younger athletic population, but then also in the older population as the knee starts to wear out. And those two tears can tear in different ways. So if we start with the younger sort of sporty athletic population that we're all accustomed to seeing, in high school athletes, college athletes, a traumatic injury to the knee, some sort of twist or pivot, oftentimes with no contact, meaning no other opponent collided with the player, but sometimes that can be the mechanism. But there's an injury to the knee, and then the patient, the athlete, may or may not be able to walk on that, but they most of the time can't continue to play, and then they present to the office with a swollen knee, a painful knee, usually on the sort of the direct inside of the knee or the direct outside of the knee, depending on whether it's a medial or lateral meniscus tear. And then at times they can have a problem with the motion of the knee. The knee can be locked where it can't fully straighten out because of a tear in the meniscus that's actually a little bit out of place and can block some of that motion. That would be sort of the traumatic one that we're sort of looking to see, listen for that type of history. Whereas the other one, which I think we'll probably get into, but the more sort of older, or you might even say degenerative meniscus tear, can present a lot more subtly in terms of insidious pain that sort of came on oftentimes slowly over time, or once in a while acutely, but without much of a trauma at all. And then it's just a more sort of subtle picture of knee pain.
Great. So Charlie, talk us through, as you examine someone, you heard that history, KG kind of went through that, but what are you looking for in your exam that, piques your interest about maybe this is a meniscus tear going on? And then talk to me about imaging, what you're ordering, and kind of talk me through those next two steps.
So I think on physical examination, first we're going to inspect the knee and see if there's a fluid in the knee joint, what we call an effusion. And that can be, especially in the younger athlete, an indication of an injury. We palpate the knee or touch the joint lines. And so we touch either the inner joint line, the medial joint line, or the lateral joint line on the outer side of the knee. And people with meniscal tears very commonly have point tenderness. They hurt right on the joint line. And that's a very good clue to there may be a meniscus tear. Then the other thing we look at, we do some form of rotation of the knee, because the injuries tend to occur as a result of rotation. So we tend to bend the knee or flex the knee and rotate it at the same time. And we feel or listen for a little click or a snap or a pop in the knee. Although those are pretty hard to come by, but we do certainly listen. But also when I'm doing that rotation maneuver, I ask the patients will suddenly like wince or jolt and jump in kind of like a little bit of pain. And I'll say, is that the type of symptoms you feel? Because when we're dealing with meniscal tears, we're looking for mechanical symptoms, not just a constant dull aching pain, but if I twist or turn or bend the wrong way, I get a sharp stabbing pain. So I try to recreate that pain with the maneuvers I do in the office. So those are my two kind of key physical exam findings. Then moving on to, radiographic studies, I'm always going to do a standing X-ray. In the young patient, generally they're not going to have any signs of arthritis, and so they'll have a normal knee X-ray. But in the older, middle-aged patient, it's really important to get a standing X-ray because we do want to determine if there's any signs of arthritis, because if their level of arthritis is moderate to advanced, it's definitely going to have an impact on how we manage the meniscus tear. So X-rays kind of help us with that. And then finally, the important study, if you want to definitively make the diagnosis, is an MRI.
Sure. Yeah, and I think we all have seen that, and that's an important point to make because, many times you may have an initial X-ray in an urgent care or a hospital, and usually the patient's laying on a table there, right? We've all had examples where you stand them up, and then there's a couple of views that coming to an orthopedic surgeon, we know how to instruct our X-ray techs to get, and you can see what may be normal X-ray when you're standing, and then you have them bend their knee, and you can really see signs of degeneration or arthritis there. So I think that's a very important point that, for those listening, even though you may have been told an X-ray is normal, getting a standing X-ray really gives you a much better idea of what the function of that joint is doing, and then how much arthritis may or may not be present. So, okay, good. So I think that's a great way to maybe segue into, okay, so we've diagnosed a meniscus tear. What do we do with this? Okay, right? So, maybe KG, I'll start with you. So let's say you have that kind of younger patient who had a sporting injury and they showed up and we had a lot of the exam and history maneuvers. How are you kind of counseling that patient, and what are you usually recommending for a meniscus tear, let's say in like a 20-year-old athlete?
Yeah, so a 20-year-old athlete with a meniscus tear, the vast majority of the time, I'm going to treat that surgically. A couple of reasons, but the main reason is that we want to stabilize and fix that meniscus and preserve that meniscus, save the meniscus, as we sometimes say, for the overall health of that knee long term. So not all meniscus tears have to be repaired. Some of them we just have to remove a torn edge of it that may be sort of getting in the way of the motion. And that's a smaller surgery, where an arthroscopy, where we can look inside the knee through small incisions and then trim out a torn little edge of the meniscus. That's a relatively quick surgery and a relatively quick recovery compared to a 20-year-old with a bigger tear is one that you really want to try and repair, meaning sew it back together to preserve that meniscus. That's a little longer recovery, perhaps a little bit longer on crutches, but either way, and the MRI doesn't always tell you which one that will be, but we're prepared to do both when we go in the OR. But a 20-year-old with a meniscus tear, most likely that's a surgical treatment plan.
Sure. And then, Charlie, as you maybe transition to that other side that KG talked about, like if you have that patient who has some mild arthritis and, they show up without an obvious trauma, talk us through how you're managing that meniscus tear once you've diagnosed it with the different exam and history maneuvers, and how you're kind of managing that.
Right. So for the kind of the middle-aged patient who has, meniscus tear, I think one of the key findings is to determine, do they have mechanical symptoms? Because the mechanical symptoms, the catching, the snapping, that's signs of, or those are symptoms related to the tear. And as opposed to somebody who comes and say, well, I just have kind of a dull aching pain in my knee, because again, we know that a good percentage of patients in that age group, like about almost half the patients who have never had any knee pain in their life, if you get an MRI of their knee, they have signs of a meniscus tear, but it doesn't hurt. So if something doesn't hurt, we kind of leave it alone. So as long as the patient's knee isn't locking or gets stuck in one position or something like that, I will tell them, look, if you leave it alone for a little while, especially if it's relatively acute, like it's only happened a few weeks ago, I tell them, if just leaving your knee alone, just going back to normal activities, sometimes the normal motion of your bones can kind of grind up and pulverize a tear, and the meniscus tear will kind of smooth itself off and the symptoms will go away over time. So that works well in actually a lot of patients, more than you would think, actually. So even when patients come in, MRI in hand, say, I have a meniscus tear, I say, well, let's just maybe try leaving it alone. Sometimes the patients say, well, doc, I have too much pain. Like, I can't handle this. I could say, well, I could give you a cortisone shot into the knee, and the cortisone alone may take away most of your pain and buys you more time to grind up and pulverize that tear. And again, it can go away on its own. But If the symptoms have lasted too long and the symptoms are mechanical in nature, then there is a role for surgery. But you also have to be careful, because if the patients have reached a level of arthritis where you would call it maybe moderate to advanced arthritis, taking out the meniscus may provide some short-term relief, but actually probably accelerates the progression of arthritis. So unfortunately, I see patients who have had a meniscectomy and they're told, oh, you're going to feel good as new after surgery, but then they realize they're not as good as new and they're actually worse. And it's because their symptoms were more related to their arthritis than they were their meniscus tear. So I think once we get into that, later in life population, even if they're very active, I try to encourage patients to maybe use surgery almost as a last resort, depending on the level of their symptoms.
Sure. Yeah, and I think this is where, we all hear, people have come in and said, hey, I had a clean out procedure, 15 or 20 years ago. And I think our field has kind of evolved from that in many ways where, there's been a number of studies that kind of give us pretty clear indications, as you said, those mechanical symptoms, that locking that people may hear, that can improve with a arthroscopic meniscectomy. But if they have more generalized dull pain and it sounds more like arthritic symptoms, that may or may not change. And we're probably really pushing non-surgical treatment for the vast majority of people. And that's, I think, where we've evolved as orthopedic surgeons in the last, 20 to 25 years, probably. So, KG, what do you think the role is for physical therapy for meniscus tears? Do you use it a lot? Is that something that you've seen benefit for your patients?
Absolutely, especially for that second category we're talking about, that middle age to from 40 on up. Those people with a meniscus tear can definitely do better if you offer them physical therapy without any surgery. I think studies have borne that out, that as many as 70-75% of patients who present with a degenerative type meniscus tear will indeed get much better with physical therapy without surgery. Some of them we will find end up developing some of those mechanical symptoms that Charlie was talking about and have to convert over to the surgical option. But the majority of people should be offered therapy because it really does help. And that's often sometimes hard for, I think, patients to understand, like, hey, doc, I got a tear. My MRI shows I have a tear. How's therapy going to fix my tear? And the answer is it's not going to heal the tear. But the reality is the other knee actually might have a tear as well, just based on their age alone, and that knee's not bothering them. So how do we get this patient, the symptomatic knee, to behave like the asymptomatic knee? Therapy can often get us there.
So getting motion back, getting swelling down, building your strength, these are all things that can help your symptoms. And for many people, it gives them options. It allows them to choose when they may want to do something surgical and work it into their schedule versus having to do it in a more accelerated timeline. So I agree, PT is a huge part of treating that. So good. So the other thing I think I wanted to dive a little bit into is meniscus repair. And I think this is something that we all agree on, that, for most people, especially young patients who have good cartilage, we're going to try to consider repairing it. And some of these are intraoperative decisions, but I was wondering, Charlie, if you can talk through the audience, like how you in surgery look at a meniscus tear and then how you think about repairing it, and the ones you say, look, I can fix this, I can't fix this. Like, what is that thought process like when you're in surgery?
Right. So, what we look for in terms of repair is a relatively clean type of tear. So in the younger patient, it's often referred to as a vertical or a longitudinal tear. If you think of the meniscus shaped as the letter C, as you pointed out, Pat, the outer 1/3 of that meniscus has blood supply in it, and most tissues need blood supply to heal, so that's important. So the location of the tear is important. If it's in that vascular portion of the meniscus, it has a much higher potential to heal than if it's in the inner portion of that C, where there's essentially no blood supply, and that may not have a great healing potential. But if it's a nice clean tear and the tissue inside the tear is good quality, you can put stitches through it. And again, the stitching is usually done arthroscopically, and you can, reapproximate or squeeze the two together with several stitches and make it look like a normal meniscus and has a chance to heal. Now, if you have some tissue, but the inner part of the C is kind of shredded up, yes, we can almost sew anything back together, but that tissue may have sustained so much damage that its potential to heal is relatively low. So if you sew that one together, it'll probably feel better for a while, but by a year out from surgery, it's probably going to re-tear, and then you're going to go back and take it out. So, it is a little bit of a judgment call, and probably the younger the patients are, we probably maybe push the limits a little bit more to try to get it to heal. And when we're talking, again, we're in that, teenage to 20, 25-year age group. The older they get, we may err on the side of taking it out if the quality of the tissue isn't particularly high and the location of the tear isn't just right.
Sure. And, KG, do you have anything when we repair it, right? So we always talk about kind of the biomechanics. We're going to stitch this together. We're going to reapproximate the tissue. Do you have anything biologically that you like to do at the time of a repair? Maybe explain how an ACL reconstruction, helps meniscus repair, and then, how we may augment a isolated meniscus repair in a younger patient.
Sure. Yeah. And this part's interesting. And we often talk to the residents about, or even teach our patients, that it's a little counterintuitive. We've learned that meniscus tears that we repair heal better in the presence of an ACL reconstruction compared to a meniscus that you just repair that didn't need any other ligament reconstruction. And there's some different theories about why that is so, but I think most of us think that it's because of the stem cells that come out of the bone when we drill into the bone doing an ACL reconstruction. Those stem cells, those marrow elements that have healing growth factors in them, those help the meniscus tear, repair, heal. And so with that, if we're just doing a meniscus repair without any sort of ligament ACL reconstruction, many of us, including I think all three of us, will do some sort of marrow stimulation, which is to do a microfracture or to drill into the bone and make a little channel to get a little extra bleeding into the knee joint to give some healing response to that meniscus, some extra growth factors for that meniscus. That's one of the main things that I do. There are other things that are out there. People talk about PRP and fibrin patches and other little ways to try and augment your repair. But I think that drilling into the femur makes the most sense.
Sure.
Yeah, I agree.
Agree. So Charlie, I want to transition a little bit because I think that a lot of people may run across the term a root tear or a meniscus root tear, and these are things that we see pretty commonly. But what is that? How is that different than what we just talked about? And is there any other pearls you have for someone who has a meniscus root tear?
Yeah, so root tears are something that has really gained a lot of attention over the last 5 to 10 years, I would say. I mean, I can tell you that early in my practice, a long time ago, no one even mentioned the word root tear, and now it's something we look for very carefully. So the meniscus, generally works because it's anchored to the top of the shin bone or the top of the tibia, and a root tear is when the meniscus pulls away from that anchor point. So there's not an actual tear in the meniscus itself, but because it's lost that anchor point, the meniscus loses almost all of its function. So now the shock absorbing capability of the meniscus is lost. So once again, just like Dr. Swan said early in the talk, we kind of break this up into two groups of patients. We have the younger athletic patients, and truthfully, these root tears rarely occur in isolation. They almost always occur in conjunction with a ligament tear. And in that population, it's important to fix that meniscus because without fixing it, you're probably dooming that knee to arthritis at a relatively early stage of life. It's a little bit more involved procedure because we have to actually sew the meniscus back down to the bone, but suffice it to say, we have the technology now to do it, in a relatively straightforward fashion. So that's the one group of patients. And then we jump forward to that next group of patients, which is the more middle-aged patient. And, they come in, these patients actually do generally have an acute onset, but it's relatively trivial trauma. I was going up the stairs, I was getting out of the chair and I felt a pop in my knee, and you get an MRI and now their meniscus is detached. And once again, the decision to whether to repair this or not repair it is really based on, do they have arthritis in their knee? If they already have arthritis in their knee and it's moderately advanced, the likelihood of going through a relatively extensive rehab to repair a root tear may be a long run for a short gain. But if you happen to catch, the 45-year-old patient who has no arthritis in their knee or very little, repairing that root tear can really prolong the life of their knee. So same thing, if we repair it, we're sewing the meniscus back down to the bone to restore the mechanics of the meniscus. And it's a very effective surgery in preventing arthritis if done in the right patient.
Sure. Yeah, I think that was well said.
I find it really interesting, Charlie, too. I agree. At the beginning of my career, like we didn't talk about root tears, and I don't think, we didn't know how to see them on an MRI, and we couldn't find them as well when we were looking inside the knee. But now that we understand them better, technology's gotten better, and we can repair them better. We can just diagnose them better. So it is interesting how that's evolved.
Yeah, I find that's the patient that shows up with a normal X-ray in a wheelchair, and they were completely normal before that. They had some sort of pop in the back of their knee, and you can almost diagnose with a root tear just on that story because they're just in so much pain with weight bearing. But everybody, the ER, the urgent care, everybody's saying your X-rays look fine. You have nothing else going on. Like there's nothing here. And usually that patient has a complete acute root tear in the back medial part of their knee. So, well, good. Well, that's about 22 minutes worth of meniscus tears. So that was a whirlwind, but I think we covered a lot of ground. And, I think in general, all three of us would agree that we're really treating cartilage when we have a meniscus tear. And, the trend and certainly the goal of ours is to preserve and, keep meniscus tissue and to repair it whenever possible. And I think that's where the value comes for patients who are watching this to go to a specialist that is adept at doing that and is not just going to trim out every meniscus tear that's there, but repair it when possible so we can preserve the joint. Certainly, I hope that you guys enjoyed today's video. We'd love to see you if you have any questions or to see us as patients. So please go to our website. If you have any further information, there's a whole page on meniscus repairs. And certainly want to thank Dr. Swan and Dr. Gatt for your time tonight. Appreciate you guys.
Great, thanks.
Thanks, guys.